good afternoon to everyone and welcome to our 51st installment of the Stop COVID Deaths webinar series. We are glad that you can join us today as we continue with the 5th season of our COVID-19 learning journey together. 2 months from the March surge, wherein the Philippines experienced an increase in COVID-19 infections in the country, mostly centered in the National Capital Region and adjacent provinces we now call the NCR Plus bubble. Medical capability and capacity have been strained to their limits, forcing most hospitals to turn away patients. Aside from the problem of bed or room availability, there was also a dilemma about multiple clusters of healthcare workers getting infected with COVID-19. What have you learned from the recent surge to help protect our health systems? Magandang umaga po. I am Dr. Albert Francis Domingo, a health system specialist, and it is always a pleasure to pitch in as a co-host for the Stop COVID Deaths webinar. Kung hinahanap niyo po siya, my colleague and classmate, Dr. Raymond Sarmiento. Huwag kayong mag-alala. He's still here with us, and you'll hear from him later in this regular Friday lunch date of ours. I always look forward to Fridays because I get to learn something new every week behind the scenes. But now I also get to share the hosting duties with a beloved mentor and a dear friend. Please welcome an adjunct faculty with the UP Manila National Telehealth Center and an internationally renowned public health communication expert, Dr. Susan Pineda Mercado. Hi, ma'am. Hello, Doc Susie. Good morning po. All right, we might be having technical difficulties with Doc Susie. We're just checking on where she is. Yes, no, just saying hello to all the participants now. We're counting up to, we've reached the 1,000, mark. Yan, okay. So checking in. Hello, good morning, Ma'am Susie. Parang na-disconnect po yata si Ma'am Susie. All right. So while we're waiting for Ma'am Susie to come back, it's always wonderful to have everyone here. And today we are going to talk about saving our systems, no? Like controlling the surge for COVID-19. It's always been about what we see, napupuno yung ospital, nagkakaroon tayo ng para bang overcapacity. We might be wondering, how do we intervene? How do we help out? How do we try to fix the issues that are surrounding this? Bakit nga ba nagkakaroon tayo ng ganong diretsahan na tumataas ang ating bed counts, so to speak, no? So I just wanted to greet all those who have typed their messages here in the Zoom chat box. So hello sa ating pong mga, now we are at 1,060. All right, so we are seeing, I'm just randomly picking pag nakita ko po yung message. Hello to Cecilia Joyce Vascara. Hello. Hello kay Belinda Hubilo Santos. Magandang umaga po. Magandang hapon na pala. No? Magandang tanghali kay Irvin Llorente, kay Ronaldin Joya. So our webinar can accommodate up to 3,000 participants. So please join us in Zoom so you can fully experience this interactive program. Napakarami po nating platforms. We are at Zoom. We are also, ayan na po si Ma'am Susie. Hello, Ma'am Susie. Good morning. Good afternoon po.
Hello, good afternoon. Sorry about that, Raymond. I mean, this happens, right? Sometimes you have a patient who flatlines, and so we have to be able to do something about it. Sige, so magandang araw po sa inyo lahat. Pasensya na po kayo, nag-drop yung internet ko. I'd like to greet everyone who's watching us, joining us on the webinar right now. For those of you who are watching on the playback, YouTube, or live streaming on YouTube and TVUP's Facebook page, magandang araw po sa inyo lahat. We're so happy that you're here, and we're so happy that you're here every Friday with us. We've got a very exciting topic. Maganda po pag-uusapan natin. Pag-uusapan natin ay yung mga surge sa loob ng hospital, no? At pakikinggan po natin ang karanasan ng Philippine General Hospital. Pero meron din po tayong ibang mga guests, and guest natin ngayon si Raymond Sarmiento. Sikat na sikat po yan. So Raymond, we will talk about Raymond later, and I hope you're okay, Albert, that I left you for a couple of minutes. So yeah, so I just want to greet everybody. Sige, Albert, over to you.
Right. So thank you, Ma'am Susie. No, welcome back. So everyone, please join us for this very important and informative session as we determine how to save our systems. Ano nga ba yung sinasabi? Ano ba yung system dito? Ito yung health system, no? How do we save our systems from the COVID-19 surge? This includes the role of technology such as, naririnig niyo po yan, yung genetic sequencing. Yan yung mga variant of interest, variant of concern. Mamaya, maririnig po natin yan, no? At saka yung sinasabing telemedicine, no? Parang ngayon, parang sanay na hindi lang pang telephone order ang telephone, pang konsultasyon pa. And the race against time to stop COVID deaths. So just to let everyone know the structure of this webinar, after the main presenter has given the presentation, we will be having a panel discussion. No, napakarami po nating mga mahuhusay na guests ngayon, mga reactors. And this will be followed by a Q&A session. Magagamit niyo po, there's a button sa baba po ng Zoom natin, yung Q&A button. Para po sa ating mga nasa YouTube or Facebook, mag-type lang po kayo ng comment and our team will be monitoring those comments and relaying the questions. All right. So, Ma'am Susie, no, meron na tayong 1,170 and counting, tumataas pa. From what I heard, ma'am, nasa 2,800, almost 3,000 ang ating mga registrants.
Yeah, and we always expect people to watch on the playback as well. So yeah, this is going to be. I think this is going to be a very good session. We're going to hear also about genomic sequencing, as Albert has mentioned. We're going to learn a little bit more about the variants. What do we know about them? And of course, how do you keep yourself safe? And I noticed we have a lot of so babatiin ko lang ibang hospitals natin, Rizal Medical Center, Amang Rodriguez, of course, from PGH, maraming nakikinig, but we have people watching all the way from Basilan, from Cagayan, and many parts of the country. Thank you so much for being with us. So Albert, let's talk about the not e-certificates, the people behind the scenes.
Right, no? So yung people behind the scenes, before we go into the next sections of our webinar, we just want to make sure that we are all prepared and ready. And let's thank those people behind the scenes. No? Maraming salamat po sa ating University of the Philippines system. So alam po natin na this webinar has been going on as number 51 na nga tayo, no, na webinar. No? So the University of the Philippines system, the UP Manila National Telehealth Center, the UP Information Technology Development Center, TVUP, the Internet Television Network of the University of the Philippines, the UP Philippine General Hospital, People Giving Hope, no, PGH, and everyone who has helped to make this learning series possible. Ang dami nilang mga mga behind the scenes supporting us, ma'am.
Right. So, alam niyo yan si Albert. Parang sanay na sanay, kasi sanay na sanay talaga siya. I just wanted to say, Albert was with me when we drafted the first concept paper for this webinar. And so it's great to have you here, Albert. And to mamaya, gisahin mo ng konting classmate mo si Raymond habang nag-present. Anyway, may certificates of attendance yata tayo, no, Albert?
Yes, meron po tayo, no? So para po sa ating mga attendees, meron tayong certificates of attendance. So there's also, para bang kumbaga pre-pandemic may certificate of participation. Syempre, nauna tayo niyan, no? So meron tayong e-certificates of attendance for those who will stay on to watch. Ano po ang passing grade? Hindi naman siya passing grade. At least 50%. So please stay with us for at least half, kalahati ng webinar duration. Hanggang 2 o'clock po tayo, no? So please take note that the name you input in your registration will be the name that will appear on the certificates of attendance. Parang contact tracing po, dapat yung totoong pangalan ang linalagay. Huwag ibang pangalan linalagay sa contact tracing. All right. Yes, okay. Ma'am Susie. So
let's go ahead now, and we're very honored to have our opening remarks speaker, the Dean of the UP College of Medicine, Dr. Charlotte Chiong. Again, haligi ng ating programa who's always with us. Welcome, Dean Charlotte. How are you today?
Okay naman. Thank you for inviting me.
Welcome, Dean.
Balita ko, napuyat ka kasi nagpapabakuna yung mga medical student. Totoo ba ito?
Yes, there are about 94 of them now in Santa Ana Hospital. Some of them finished already. And so I would like to thank Yorme, Isko, and of course, Director of Santa Ana, Dr. Grace Padilla, and our Director, Dr. Legaspi, for making it all happen for our students. Kasi po, babalik sila by June, July for their anatomy dissection, especially the first year or LU3. So we want them to be protected even before they come back for their bridging courses.
Oh, Dean, baka naman may mga nakikinig dito na ibang mga medical schools natin. Is this true for all medical students? They can now be vaccinated?
Yes, if you can check out, Dr. Mirna Kubotahe actually released a memo that all medical students who will be doing face-to-face rotations or face-to-face classes can actually avail of vaccination and be included in the A priority list of the vaccination program of DOH.
Okay.
So
I
all you
think
need to do is
Albert,
get that
yeah.
memo po and siguro try to make representations with your LGUs.
Yeah, you know, our topic is really save our systems. And Albert was pointing
Yes.
out that we really have to think about how are we going to produce more doctors? Albert, did you want to talk a little bit about that before we proceed?
Yes, ma'am.
with
Actually, no,
Charlotte's
it's
question?
really good to find out na parang A1 na, no? Kasi medical students, ang pinagkaiba lang po nila sa medical doctors ay ang lisensya. But they are essentially at the bedside also. They're also facing the patients and hindi ano lang po yan, baka yung iba sa kanila buwan lang eh. Yung iba, 1, 2 taon, magiging doktor na rin po yan. And not only the medical students, also the nursing students, the paramedical students, these are the future healthcare workers. By the way, today, if I'm not mistaken, is Health Workers Day. No? It's being celebrated, ma'am. No? So, napaka-swak na swak. Pasok yung ating vaccination campaign. So, I'd just like to emphasize yung sinabi ni Dean Charlotte Chiong, no? Para po sa ating mga nakikinig na mga deans of other medical schools and also nursing and paramedical schools. All of those students, no, health students, are part now of the, I think, A1. They're considered to be A1 sa vaccination. So please get them vaccinated already. Yes, Ma'am Susie.
Okay, great. Okay, so that's great. That's great. I mean, I think napagtatagpi-tagpi natin, natatahi-tahi natin yung mga ideya na yan. Anyway, Dean Charlotte, please go ahead with your opening statement.
Well, I'd like to welcome all our attendees to this 51st episode of Stop COVID webinars. This is, of course, thanks to TVUP, Director Gigi Alfonso, VP Elena Pernia, and of course, the WHO Health System expert now that we have as co-host is Dr. Albert Domingo, and of course, the adjunct faculty for NIH and envoy for global health, Dr. Susie Pineda. The title is SOS, and that means save our systems from the COVID-19 surge. Over the past year, we have really looked at the multifaceted problems facing this pandemic. Worldwide, there are now about 155 million cases that have been reported, 92 million recovered, and 3.25 million have died. In our country alone, about 1.07 million have been infected, 993,000 recovered, and about 17,800 have died, including, of course, our esteemed faculty members here at the UP College of Medicine, our alumni, family, and even friends. Now, PGH is one of the 3 COVID referral centers declared by the DOH on March 20, 2020. And it opened as such 10 days later. So we saw a flurry of administrative changes, closing of wards, engineering controls to convert century-old pavilions to negative pressure areas, innovations in computerizing our electronic medical records, providing gadgets like RxBox for telemetry, telekamustahan portals for our patients. More than 14,700 testing of healthcare workers have been performed in a 1,500-bed hospital that used to see 600,000 patients that now has a decreased capacity from 30 to 60% depending on surges at several time points during this pandemic. We've always considered the hospital as the last bastion for this war against this virus. PGH is where the fiercest among us do battle in the trenches. In a university hospital setting, our faculty continue to teach, while infection prevention and control lies at the very core of having PGH remain open to serve the public. There have been struggles also for the college to ensure that we graduate a new crop of competent doctors, and hence we've been pushing hard for services for them, early vaccinations, for them to be able to join us and learn to be compassionate doctors. I recall emotional town hall meetings with the director to convince our future medical doctors, the interns and clerks, to come back already for face-to-face rotations amidst their fears and trepidations. And we were ensuring them that we will take all the precautions to make PGH safe with PPE provisions, safety protocols in place that they should follow. 14 months in this pandemic clearly made us realize we could only survive this if we work together in unity. With Variance, a community effort where all help out to make the trenches safe for our doctors in this field of battle. And what might not be discussed here today, but should probably be also touched on, is that local leaders, barangay captains, people's organizations all help ensure that the communities outside of hospitals are safe. As our hospitals ran out of beds and our healthcare workers got sick and infected, our health systems almost were considered to be failing. Health permeates all communities. Systems in the local and national levels have so many learnings from this pandemic. Science-based solutions mixed with cultural, economic, societal interventions will need more interplay. There's still a long road ahead of us, with barely only 2.5% or so of our population vaccinated at the present time. But this afternoon, let us learn some more from our experts on how to deal with surges inside and outside the hospital complexes we healthcare workers work in. Our profound thanks to Professor Nina Berba for yet another presentation on our experience in PGH, to Director Legaspi, NTTC Director Dr. Raymond Sarmiento, NIH Executive Director Dr. Eva de la Paz, and of course, East Avenue Medical Center Chief Dr. Alfonso Nuñez, whom I'm only meeting for the first time here in the Zoom meeting, although I did perform the first cochlear implantation in East Avenue Medical Center about 3 years ago. I'm sure our conversations this afternoon will give new insights and better ways of dealing with COVID-19 in our country. Bangon, Pilipinas. Over to you, Albert and Susie.
Okay, thank you very much.
Po.
That was Dean Charlotte Chiong of the UP College of Medicine. And we're going to have you, Charlotte, come back later for our panel discussion. Thank you for a very inspiring message as always. Okay, Albert, let's go to our Mentimeter opinion poll.
Yes. So punta tayo ngayon sa ating opinion poll, no? So ang laki na nga ng pinagkaiba, Doc Susie, no, Ma'am Susie. I remember when we started yung opinion polls nandito lang sa loob ng Zoom, but now because we have many watchers even on Facebook, on YouTube, so gumagamit na tayo ng menti.com. So bring out your devices, yun pong inyong mga phones, mga computers. Pagpunta ho tayo sa website na www.menti.com. Please use the code 7557-8216. Okay, 7557-8216. And this will allow you to answer the first question, which is now displayed on screen. Yan, para tong board exam. Biro lang po. When is a symptomatic patient most infectious? Yan. When is a symptomatic patient most infectious? And the choices are A, upon exposure to confirmed COVID-19 case. B, day 1 of the appearance of symptoms, or C, when you get the results of your COVID test. So please try to answer. No, when is a symptomatic patient most infectious? This is an anonymous poll, no pressure. Just use the Menti code that you see there, 7557-8216 on www.menti.com. While our viewers are answering the poll, i-acknowledge lang po natin, Ma'am Susie, no, Doc Susie, yung mga ating well-represented audience. Nabanggit na kanina ni Ma'am Susie, no, we see participants from all over the country, sa Cagayan Valley, Region 2, sa Kalinga, Cordillera Administrative Region. Meron rin tayo mula sa Sorsogon, sa Kabikulan, sa Siniloan, Laguna, in Calabarzon, and all the way from Basilan, Zamboanga Peninsula. No? So ang dami talaga nating mga parang participants na nag-join from all over the country. So based on our Mentimeter, ayan na, tignan natin, ilan na po ba ang sumagot, no? So we have the following responses. We have, 236 responses at ang karamihan po ay sumasagot na 198. When is a symptomatic patient most infectious? On day 1 of the appearance of symptoms. So tignan natin kung tama yan. Mamaya sasagutin niya ng ating mga speakers, ating mga panelists. But before we go to that particular level of detail, no? So wag nating kalimutan na meron pa tayong mga ibang pwedeng sagutin na questions. Wait for those to come out later. And this is the second poll question now, no? Lalabas na ngayon. Why is it important to do genomic surveillance of emerging variants? Para sa ba natin ginagawa yung genomic surveillance, no? And still the same Menti code, 7557-8216. Ang ating mga choices, A, It will help detect if a variant spreads more quickly in people. Huwag kayong maniwala kagad dun sa unang sumagot na ang dami kagad, pero malay yun talaga yung sagot na. B, it will help determine if a variant evades specific diagnostic tests. C, it will help detect if a variant causes more severe disease. D, it will help determine if a variant can evade vaccine-induced immunity. At mukhang mga nagbo-board exam yung sumagot ng letter E, all of the above. Pero meron rin pong F, none of the above. So please choose your answer. Why is it important to do genomic surveillance of emerging variants? And while everyone else is still answering, tumataas pa po, nakikita ko yung numbers na tumataas, no? Let us now acknowledge our international viewers. Ma'am Susie, meron tayo mula sa Ministry of Health, Bandar Seri Begawan in Brunei, from Taipei City in Taiwan, from Ho Chi Minh, Vietnam, from Simpang Ampat, Malaysia, from Bandung, Indonesia, North Delhi, India, Dubai, United Arab Emirates, from Saudi Arabia in Riyadh, from Doha, Qatar, from Muscat, Oman, Salmiya, Kuwait, Islamabad, Pakistan, Pordenone, Italy, from Corona, California, United States, and the Niagara Falls in Ontario, Canada. Napaka-welcome po all over the world ang ating participants, not just from the country, but also all over the world. We have members also of the medical and academic community, Municipal Health Office Gataran in Cagayan, RHU Tanudan sa Kalinga, Ikapit Bisig Mo Community-Led Development sa Laguna, Metro Health Specialists Hospital Incorporated sa Sorsogon, at ang Basilan State College mula sa Basilan, Zamboanga Peninsula. Please join us. Welcome po every Friday at 12 noon. And only para sa ating mga viewers na nasa YouTube and Facebook, please feel free to answer in menti.com. The code is 7557-8216. At mag-comment lang po kung may mga questions, mababasa rin po natin yan. So Ma'am Susie, ang dami nang sumasagot. Tingnan lang natin yung response. Mabilis lang, mukhang nag-all of the above ang ating mga respondents. Malalaman natin kung yan po yung tamang sagot. Abangan natin sa ating speaker. Over to you, Ma'am Susie.
Okay, thank you very much, Albert. And yes, we'd like to welcome all the international participants in the webinar. Sometimes we speak in Filipino. Well, a lot of the international participants are Pinoys, but I understand we also have quite a bit of people from health workers from other countries. So we really welcome you. And just very happy to share what we know here in the Philippines with you, and hope that we can also learn from you. So there's a Q&A box, there's a chat box. We try as much as possible to be interactive. And I think as we go along the webinar, please feel free to ask questions in Q&A. I said this the last time that while we may not be able to answer all your questions, the Q&A box helps us get an idea of what you're thinking, and maybe we can ask our speakers to address that. So use the chat box, and be involved and be engaged with us. So we typically have a person on the street interview prepared by TVUP. And Albert, do you want to cue that?
Yes, let's see. Tignan natin, no? Ano ba tong person on the street interview? Let's watch this short video by TVUPs. Answering, bakit napupuno ang mga ospital dahil sa COVID-19?
Sa aking palagay, kaya tumataas ang kaso ng COVID-19 ng mga napupuno sa ospital ay dahil sa kakulangan ng kaalaman ng mga tao regarding sa COVID-19 na sakit.
Hindi naman po may iwasan din nung ibang tao na lumabas-labas pa rin kasi yun nga po, kailangan din po kasi talaga nilang maghanap buhay.
Factor pa dyan yun, napakaraming variants, napakaraming surges sa communities and workplaces.
Well, for me, it's the variants. And then...
Hindi po kasi lahat talaga may kakayahan po na kumuha ng pera or yun nga, bumili po ng pagkain. Kaya siguro, dahil po doon sa paglabas-labas din talaga ng tao, may posibilidad po din nakakahawaan.
Naging kampante yung mga tao, kaya parang dahil po doon, naging confident po sila siguro na, okay naman na pala tayo dahil may vaccine na. Okay na ulit na hindi tayo masyadong hindi masyadong mag-ingat.
Ano na rin isang taon na tayo ng ganito So syempre, ano na rin tayo, maraming kailangan lumabas, hindi lang para sa trabaho, pero gusto nang makita yung mga pamilya nila, yung mga kaibigan nila.
Karamihan din dito, hindi lang naman kaya ng home isolation, kailangan nila ng medical management na hospital lang yung makakapag-cater doon.
Iba naman na tao na talagang critical, yun naman yung hindi nabibigyan ng tamang atensyon. Kaya nangyayari, napupuno ang mga ospital ng COVID-19 cases.
Ibang nakakaranas ng karamdaman or sakit ay nakahalo na rin dito sa mga COVID patients na marami.
The Filipino people, they're starting to get vaccinated. Siyempre, we still need to be safer, especially now. Yun nga, nababakuna na tayo. So hopefully, it will get better kahit tumadami na yung cases. And
Pag-isipan po natin yung mga bata ng henerasyon po ngayon or gawin po natin to para sa kanila. Kumbaga, kung matatapos man po yung laban na to, sana sa atin magsimula at sa atin din magtapos.
In the future, magiging careful na po lahat ng tao pagdating sa health nila. Siguro po magsuot na nga ng mask or yung iba mag-iinom na po ng vitamins, ganun.
I fully believe in the vaccine. Ako hope ko talaga na parang yung herd immunity, na sana everybody here na they would pumayag yung mga Filipino people to get the vaccine, diba? So we can all grow and, get better.
Okay, sorry. Thank you very much. Thank you very much, TVUP. I think it's always very helpful to get a perspective of ordinary people. What do they think is happening? And our topic today, Save Our Systems, and dealing with COVID surges inside hospitals is really a very good theme on Health Workers Day. Dahil haligi talaga ng response yung ating mga health workers, no? So papakinggan po natin kung paano po mapoprotektahan ang ating mga health workers ngayon na dumadami pa rin ang kaso ng COVID-19. So our special presenter for today is somebody who's not new. You've met her many times. She's the head of hospital infection control at the Philippine General Hospital. Dr. Nina Berba. Nina, welcome to the webinar.
Hello, good afternoon.
Kumusta ka na dyan, Nina?
Eto, waiting for my turn. Hello, everybody.
Okay.
Game?
Yeah, go ahead, Nina, and make your presentation. Go ahead.
Okay. Good afternoon, everybody. So, let me... There you go. All right, so save our systems from the COVID-19 surge. So these are my objectives to demonstrate how timely contact tracing may help manage outbreaks or surges, and to describe some of the various tools that we can use to manage COVID-19. So this is my outline, and I'd like to start just describing a little bit what we've been doing at the PGH. So this is our beloved PGH. It's been designated as a COVID referral center for over a year now. And this is our office. This is what we call Hospital Infection Control Unit. That's me over there and our staff and what we do. So if I were to describe what the top 3 best practices of PGH have been and our contribution to the COVID-19 response, I would say that it's this. So side by side with what's recommended, we tried to really use the science to have better engineering controls, better administrative controls, and the proper PPE. So yung engineering controls, we did it this way. So while many people would invest a lot of money on negative pressure settings, what we tried to do was what we called controlled ventilation. And it looked something like this. We had really big open wards, and we tried to achieve the recommended 12 air exchanges by actually controlling the movement of air and using this foolproof devices to make everything work. We also had this administrative controls that I think was also key to our good operations in the COVID-19. And finally, the HICU-based risk-based levels of PPE, which tried to adapt with what was happening elsewhere and according to the levels of evidence. So how did we know we protected our staff? No? Kasi panay may question of baka magkaroon ng surge. So early on, we actually did a hospital-wide COVID-19 testing at the 3rd month of operations. And we saw here the really very extravagant, unprecedented high participation of all staff members of the hospital. We have about 5,000 people in the hospital, and 4,871 participated in this hospital-wide surveillance. And you would see that at the end of it, we noted that only 2%, so 2% lamang ang may COVID-19. And that was really very remarkable. And when we tried to disaggregate the numbers, we saw that the numbers were actually better in some areas. And even in the areas where doctors and nurses were working actually in the COVID wards, they did very well. But this kind of approach was very, very expensive. We wouldn't be able to sustain it on the long term. And we felt that targeted testing was really better. So that was what we did along the way. And as Dean Chiong was saying, we actually encouraged targeted testing, and we were very generous with the numbers of tests that we actually did. Whenever our healthcare workers would feel like they need to get a test or they were exposed, we allowed them to have the PCR testing. So in this graph, you would see that the tall light green graphs or bars represent the actual number of tests done, and the little darker shades of the bars represented the ones that had positive tests. So along the way, we actually really tried to monitor our healthcare workers. And I think that's very, very important, anticipating whatever will happen with the COVID-19. So we had surveillance in the form of mass testing, as I described earlier. But along the way, since we felt it was not economically sustainable, we targeted only the COVID staff. So that happened 3 months later after the June mass testing. So we had surveillance number 2, where we noted 4.2% infection rates. And throughout the year, there was this targeted testing on demand whenever they feel they needed. So in the end, we had these numbers of infection rates that guided us as to how we would go about operating as a COVID referral center. So I think it's very important that our audience here have, or particularly managers of our different institutions and communities, have some kind of an idea of what your epi curve is in your vicinity, in your community, in your institution. So we did something like this. We always plotted the number of infections on a per day basis. And we actually had the definition of what's community acquired COVID, that's community acquired, or that came from the household or community, or occupationally acquired that came from the hospital. So we were already there. You see that the numbers have gone down around November, December, January, February. We were experiencing just very, very few cases. And there were days that we actually didn't have infections anymore. So we were very, very comfortable. And at that point, we felt we're already almost 1 year into this. We needed to know exactly how people were doing, who were infected, how many were infected, what were we doing everything correctly. So we thought of shifting gears from PCR testing to immunosurveillance or serosurveillance. So we asked for volunteers from across the staff and tested them with anti-SARS-CoV-2 antibody in the form of the IgG. And in the end, we categorized people to positive or negative. So here, we realized na yung positive at negative, it doesn't end there. It's not as simple as it seems, because the negative ones, sometimes they were once sick or never sick. And the positive ones, we think were sick, but there were people who tested positive, but actually were never sick or were never detected to have been sick with PCR tests. So in the end, our serosurveillance results came out like this. We wrote here all the possible permutations, but nevertheless, you could see that yung non-reactive IgG didn't have antibody and was never sick. That means never really had COVID-19 in the last 11 months. No, that was 74%, and we were very happy with this result. We felt reassured. We felt affirmed that the operations were safe. And there was in the last part of this table, you would see there were persons who reported never having been sick but tested positive. So this we thought were the asymptomatic healthcare workers, but they were not very many. They were only 8% of the total number of staff. So this is where we were, yung bago mag-surge. Ito yung context that I wanted to just establish. We were comfortable, we felt safe, we felt proud that 74% of us remained COVID-free, and we felt this was a very good number. We were just waiting for our vaccines. And if we compare those numbers with other places in the world, in the same setting and at the same period of the COVID-19, we felt that our numbers were comparable, if not even lower. Okay. So, eto na, dumating na yung surge. Then we experienced the emergence of the new surge. And for you who are watching, maybe the main question is, how do you know it's an outbreak or a new surge? So we started to see change in our numbers as early as March 1. And at the time, the DOH numbers were just that. Parang wala pang premonition that a surge was coming. And our epi curve looks something like this. So comfortably, we were showing our daily reports, and it did say nothing much was happening until there was some start of some traces that something was indeed happening, and there was that surge. So we needed to make the call. So for you again who are watching, parang mahalaga yun. It's very important when to make the call, when to tell your staff or your colleagues or the people around you that, hey, alert, alert, we need to be more vigilant. So we did that on March 4. And then parang napraning kami, no? Repeatedly may mga alerts because things were not going down despite efforts. So it started off, how did we know there was something going on? So in one department, we had 4 cases in a span of just 4 days. And then in a span of like just over a week, we had 8 cases. And that triggered us to really investigate and call and quarantine 36 other people. So that was a large number already. And then because you know, we don't work in silos, we work together in the hospital, we needed to look at what happened beyond that particular Department A. So we started to look at Department B. And here we saw that we needed to quarantine 91 people. So together, that was already over 100 people quarantined in a very brief period of time. And in the hospital, that really meant maybe crippling some very important essential operations. And then we started seeing some other places. In Department C, there was this webinar that happened face-to-face, and then there was a lecturer that turned out to be positive after the webinar, and then had some infections there, and we needed to quarantine other people. And the same goes for Department D, wherein people started to, you know, as we usually do, gather around together and eat for a period of time. So during that time, at the first few days of this called quote-unquote surge, we figured out that we thought that people were coming in to work despite symptoms, because when we interviewed them, they already manifested with some kind of symptoms related to COVID-19 days before their positive test. And then they would go around the hospital, maybe eat together with other colleagues, and infect more and more healthcare workers. So we needed to stop this particular process. So we came out with the future memos that said, well, do not come to work if you're sick or have been sick in the last 3 days, and do not eat together. So parang madali lang sabihin in memo, but it's really, really very hard to make people believe and comply. Okay. And then we started to think, is there the presence of variants of concern already among us? Why is this happening? So this is one of the things I'd like you all to take home from this particular lecture, that when people come to work when they're sick, it's it's really like heralding the possibility of more outbreaks, because a person is most infectious. So tinanong to during the Mentimeter, the person is most infectious just around the time before the symptom onset. So, and very high during the first days of illness. And then it starts to decline within the 7 days. I'm very happy with your answers, because it seems that you really knew about this infectiousness. But when you start talking to patients and start talking to people who have been infected, they start isolating themselves only after they hear about a positive PCR result. So matagal na silang infectious, they've already infected many other people. So that's something I'd like you to take home, and I'd like you to share with your family and friends and people in your workplaces. And then the story in PGH continues, no? So there were other departments that started to have more infections. So we were really, really very bothered when some people in the vaccination program developed COVID-19 also. And then more offices and more departments. So we were wondering what was happening. Why were the number of cases really so explosive? So we learned eventually that we were actually invaded in a way by the variants of concern. So we had the South African variants, many of them. And then we also experienced within our midst a lot of people ending up with the UK variant. Some of them were patients and some were watchers, but many were healthcare workers. So we experienced the variants firsthand within what we heard in the radio. We actually experienced it in our hospital. And we felt that the surge really was only partly the variants of concern, but many also was related to many more things we needed to improve in our system. So yung sinasabi kanina, matigas ang ulo, naging ganyan talaga yung naramdaman namin. But it was very, very important that we secure the PGH workforce, because the last thing you'd really want to do was for this variants and the surge to overcome the operations of the COVID-19. We needed to keep everybody safe despite the presence of the surge within us, and make sure that we try to reduce the number of people infected. It was like taking care of those people who take care of others. We didn't want to close any of the wards, and we didn't want to close our operations. So it's important for you guys to understand that in this point in time, marami na tayong alam, tapos marami na tayong PPEs, marami ng improvements, engineering and administrative controls. And with all of those layers in place, healthcare workers probably do not get their COVID infections anymore from the wards. So where do they get them? So this review actually tell us what we've also been experiencing. So transmissions occur outside the COVID wards. They occur in our offices. They occur when we eat. They occur when we don't take care of ourselves and do not follow infection control prevention policies. And it may happen while you are commuting from hospital to home, with your families and in your communities. So the last place that the healthcare workers might get their infections are actually in the hospital when they're wearing their whole PPEs, no? But it's very important to secure the healthcare worker force, because when our healthcare workers, when our frontliners are infected, then they may continue to infect other healthcare workers and even patients. So after the rapid rush of variants invading us, we had to impose something like a martial law. We had harsh rules imposed to stop the transmission. So ito po yung mga ginawa namin. We started to require a negative swab. We had new rules in place. We started to call back people. We were very, very strict with what people were doing. When they were exposed, we made sure they were quarantined. We made every effort to really stop the transmission. PGH employees who had household contacts, knowing that they're very highly likely to be the next one infected, we put them in quarantine already, and we didn't allow them to work even if they were not yet infected. So quarantined na sila by virtue of high exposure. And for those who had the variants, we imposed that they had a negative swab before they returned to work. So yan. So syempre along the way, maraming nagalit sa HICU, no? But that's something we needed to do. We also looked at all the departments, all the areas, and when there were 3 or more consecutive positive COVID cases, we asked them to close temporarily, disinfect, and make sure people were okay before we reopen. So yan ang mga nangyari. So those are all the new initiatives that we did to just make sure that we were working promptly on all the possibilities. The most important of which was really to make people understand that when they're sick, they need to stay at home. They need to reduce their social mobility also. Okay, so yan yung mga we again reminded everybody of the pandemic precautions, the apat-dapat. And then we looked for the safety officers. We reinforced. We had this in place before, pero mukhang nagiging lax. So we had to find stricter people to make sure that all the regulations, the new regulations, were followed. And we even yun question na, ang hirap naman yung meals. Paano nyo kinontrol? So even the meal times were managed. We had to ask people to stagger their time that they ate. We tried not to have people eat together. We fixed the pantries, we fixed the cafeteria, and we tried to set up alternatives. Tapos we actually didn't look into this before, but because of the surge, we had to look at them. Yung mga call room and mga lounges, the offices, we had to make improvements on them on top of everything else before. We made sure they were transformed into well-ventilated spaces. There were spaces between beds and tables, and we had to purchase additional HEPA filters. So yan. So yung risk communication had to be again reinforced. We communicated in English and in Filipino, just that everybody we made sure that everybody understood what we were trying to say. But in the end, ito talaga glaringly, talagang nagka-surge because for the month of March alone, that already comprised almost 30%, 1/3 of the total infections we had for the whole year. So that was really a lot of numbers. And when we disaggregated the data, we saw that many people actually did get the infections from community or household. So in this particular graph, they are represented as orange and as gray bars. No? Ano ibig sabihin nung from community? What did it mean? So when we asked people, they would say They had a birthday party at home. They attended the funeral. They went on outing. They actually went to commercial places like had the massage, went to the parlor, and things like that. So we weren't really having reduced mobility. We were actually moving around, and that added to the positive cases. What did we mean by the PPE breach? So in the graph, they were represented as green bars. So that means hanggang dun sa 11th to 12th month, there were still some staff who didn't seem to understand the necessity of following all the guidelines or the health precautions. No? So we had to, again, review and remind everybody about this. And then what did it mean when from a coworker? So this meant that they may have eaten together or during duties slept together or worked together without physical distancing. So this is where the safety officers were needed. The safety officers sort of hovered around departments and offices and made sure people were complying accordingly. So here, in the community, when somebody gets sick, you tell them, oh, sige, isolate yourself, or when others are exposed to this person, you ask them to quarantine. And sometimes that really doesn't add up to a lot of difficulties. No? But when you're in the hospital, when you start quarantining people who actually were just exposed to some positive persons, then that adds up to a lot of people who need to be quarantined. You pull them out of where they're supposed to work, and you end up having very, very few healthcare workers left to keep the operations of the hospital. So here, yung yellow bar is represented here. And that represents the total number of quarantined. And we really, in addition to trying to limit the number of people infected, you also have to limit the number of people exposed and have to be quarantined kasi it really it causes so much disruption in your operations. So if kunyari meron kayong operating room, you might need to close that because you don't have enough nurses because they're all under quarantine. So you would see here that in the month of March alone, we had to quarantine 268 healthcare workers. So ang dami-dami kailangan mag-rest and mag-leave. Okay, so in all of this, it's very, very important to realize that contact tracing, timely done at the right timing is key to controlling whatever outbreaks you experience. And it might be so complex. So nilagay ko lang dito, you don't really need to read that, just that you appreciate that they can be very complex and you really need to rely on what the well-trained staff of infection control or the contact tracing team in your communities will advise you. There are high-risk exposures. So in the hospital, these are exposures that happen because you're not wearing proper PPEs or you're not following exactly the what's included in the pandemic precautions. And all of this make you at risk for getting the COVID-19. Okay. So the algorithm can be very complex and it does require some knowledge and a lot of skills in communication. So we'd like you to just ask your contact tracers to help you with this, or your infection control committee in your hospitals. Pero itong lahat na to, the martial law, actually we had to do them only for a brief period of time, 2 to 3 weeks. And as soon as we felt that things were coming back to normalizing, we were able to maybe nip the outbreak at the bud. So we were by April 1, just 1 month after we called the first alert, we were able to go back to previous programming. So after the storm surge, we went back to our previous policies. Whereas before, we asked everybody to be swabbed repeatedly. after the storm surge, we felt it's safe already. We realized that it wasn't necessary and that we didn't have surges beyond the places where the initial variants were seen. So this is now our epigraph. So you would see na parang tapos na talaga yung surge. We're very happy that in the last few days, there have been days that we didn't have healthcare worker infections anymore. And actually, we were able to declare that despite the multiple PGH exposures to the variants, we didn't really observe, we were not able to observe that this cluster actually led to more and more of the other areas being involved. So we're very happy. What happened to the variants? They recovered uneventfully, but we felt that even before the results of the DOH. So ang message dito, you don't have to wait for DOH to say na, oh, may variant kayo. You don't wait for that. Early contact tracing at the point in time that you know about healthcare workers being infected, whether variant sila or non-variant, you have to get them isolated immediately. Okay. And we also did not see any additional generations of infected or high-risk contacts beyond the initial set of variants we saw. Yun. So lessons learned. I'll have to cite some of the other clusters we studied before confirmed by whole genome sequencing. And this is all about looking and opting for safer choices. Okay. So cluster one, so this next set of slides describe our data on clusters. So we found clusters before of infections. Tapos we thought, siguro magkakamag-anak tong mga clusters na to. And we tried, those were the hypotheses. We sent the samples to the Philippine Genome Center and they were very glad to help us and actually helped us describe the characteristics of the virus. And we found indeed that they were interrelated. The genome sequence were very, very similar. So this cluster started off with the one on the leftmost side. Lumalakad siya sa ospital. No? He interacted with a lot of other people. And their kind of work made them move around the hospital. And what we found out was it was very important that people wore correct PPE all the time because any kind of breach in PPEs would lead to infections like this that you can trace all over the hospital. Cluster 2 is about people who moved through or traveled through a carpool. So carpools are sort of like a high-risk setting because people are together for long periods of time inside the closed space. And when one person in that carpool gets infected, he would inadvertently infect the other people in the carpool. So that's something you have to think about if you're part of a carpool and practice more vigilantly your PPE use. Here you see that one of the people was part of a larger cluster. So yan, cluster 3 describes a cluster wherein that person actually continued to go to work. No? So there was just one index case who came to work even if he felt sick and actually infected everybody in that office. So the message there is when you are sick, you stay at home, you don't put everybody at risk in your office. And cluster 4, we needed to do this because they didn't want to believe us that it was the eating, that it was the sharing of meals, it was that sharing of space when you weren't wearing your masks that should be avoided. So even if these different people came from different offices but spent some time during the day together eating, that they got infected and the virus that they had were all the same. And finally, cluster 5, I want to show this to you because this is an example of a face-to-face interaction without full PPEs. And even if you say, well, we only met for like 5 minutes, we needed to do it, nobody else could do it, we had to have this meeting. The message here is really no one is indispensable. Whatever you know, whatever data you have, whatever it is you need to do, you can like just pass it on to another person, especially if you are already feeling sick. So symptomatic people, even if they're just in the office or in the hospital for just briefly, they can infect others. And you would see here that everybody in that group, in that meeting, actually got infected. So choose safer activities. Kung pwedeng mag-usap-usap virtually, then do that. And all of this were affirmed and confirmed by the PGC. Yun. So this is where we are now. I think we can safely say we were able to overcome the surge of March 2021. The graph in the bottom shows na parang back to usual na kami. Hopefully it will stay that way, but we're really, really very, very careful at this point in time. And as of, we actually, over the last few weeks, we have gone over the 1-year celebration. Di kami naka-celebrate because of this surge, but we're happy to say and we're grateful to everybody who helped us through this difficult year. So my recommendations, what works in PGH should work for all the other communities in our country. But we all need to be guided by science. We need to find solutions. We need to implement by systems approach. We need to be together in solidarity and always strategically use communication as part of your strategies. These are my teammates, partners in crime. So sa bottom are the contact tracers in the HICU. That's Ma'am Jeremy and Ma'am Mary and Ma'am Merly, who I'm very grateful to always, and the COVID crisis team on the left upper side. So thank you very much for your attention.
Wow. Thank you very much. That's Dr. Nina Berba, who is the head of the Infection Control Unit of the Philippine General Hospital, and really demonstrating the extraordinary measures that have to be taken in a hospital in a time of a surge. Kasi parang parang yung surge umaabot sa hospital, from the community into the hospital. Okay, we're going to, Nina, while you're taking a little bit of a break, take a look at the Q&A box. Lots of interesting questions there. And the chat box also has some very good comments. Okay, so I'm turning over to Raymond for our next reactor. Raymond, go ahead. I mean, Albert. Sorry, Albert.
Mamaya pa po si Raymond, wag kayong mag-alala. But thank you so much. Thank you, Ma'am Susie and Ma'am Nina, Dr. Nina Berba from the Hospital Infection Control Unit of the Philippine General Hospital. We mentioned that we will be hearing from Dr. Gerardo or Dr. Legaspi of the Philippine General Hospital, the director. He is able to send a video for now due to another pressing concern he has to attend to. So let's hear from the video of Dr. Legaspi.
It's always a pleasure to hear Dr. Berba talk about new things in COVID-19 operations and also rehashing of lessons that we've learned. And I think this current surge has proven that, again, basing our actions on good science is what gets us through this pandemic. We very well know that the increasing number of cases came at the time that we were turning around a year old as a COVID referral center, and we are about ready to celebrate that or commemorate that at least. But the surge came, and again we had to adjust and calibrate according to needs of the time. So the COVID crisis committee is composed of senior surgeons, well on their way in life, but almost all males, but we all listen and we don't move unless Dr. Berba tells us to do so. And this is one of those moments that we did, and I'm happy that we have her in our team and to guide us on the next step. So for this particular situation that on hand, we again employed the personal reduction scheme as the first step, and that initial step that we took was to send home our interns and clerks who were already spending around almost 2 months in the wards, no, 3 months in the wards, and of course it was something that was difficult for us to do, but I think for the safety of these students, we had to make that decision, knowing that if they don't get infected from patients, they probably will be infected from among themselves or some other personnel in the hospital, and we don't want them unnecessarily exposed to that. So that's quite a number of them. There are 180 interns and around the same number of clerks that were sent home for that particular period. And of course, the adjustment in the capacity to hold patients also was done. Prior to the surge, we were just operating one ward of around 35 for COVID charity patients, and then a floor of around 30 beds for our COVID pay patients, and around a few 9 beds each for pediatric and obstetrics COVID cases. And of course, we still had our 18-bed ICU capability, but with the surge, we were forced to open additional 4 wings, and the personnel needed to run these wings is at least twice that of the regular ward. So we were forced to close a few wards. We closed wards 8 and 6, so that we can divert the personnel, nursing most especially, to the other open wards that we have. The reason for having more people, more personnel, including doctors, in the wards was that I was very particular in the fact that our personnel should have protected time for resting, so that after a year, of course, all of the anxiety and the stress would have taken its toll, and then again the surge comes. So I think it was only right, for not knowing how long this surge will run, to schedule even the rest periods, even more than they had in the previous surges that we had. So we were fortunate to have augmentation of doctors and nurses as well, and the feeling of confidence and less anxiety was palpable in the wards when you make rounds. So we were able to ramp up our bed capacity to around 250, and at a certain point in time, we reached around 243, filling it up almost to capacity. Of course, the usual problems were there: oxygen ports that were not functioning. For a time, we had a shortage of high flow nasal cannula units, and fortunately, we're able to outsource this and add another 15 to our then 22 units available for our patients. So this tided us over until now. I think we are needing less of this. I think with the increasing number of patients, the increasing need for medications is also felt not only by us, but by the whole country, probably, especially the NCR hospitals, because remdesivir and tocilizumab were running out. In the beginning, we were still able to even share our stocks with other hospitals, because I think it's our duty to, of course, alleviate these conditions of people we can help outside the hospital. But unfortunately, we also ran out eventually, and sourcing it was really a big challenge, and it took a lot of wheeling and dealing to be able to come up with the appropriate stocks for this. But as we went along, the supplies came, and I think for remdesivir, we're waiting for our final delivery to come. So the logistical requirements of adding more people also to the COVID wards necessitated more accommodations for them, because our philosophy is that if they serve in the COVID wards, as much as possible, we want them near the hospital so they don't have to travel much and lose time that could have been used for resting. So we again employed the use of our facilities in UP Manila, the colleges. We got support from IATF, and we were able to house at least additional 100 people going on duty in the COVID wards. This is probably one of the most challenging parts also of the responding to the surge, is managing the transportation, and that has cost us a lot of money to run. But of course, very much what we pay for, because the feedback from our staff is that it really gives them a sense of appreciation. And that's number one. Number two, a sense of safety, because they know everyone who's in the vehicle or in the shuttle. More or less, they know the status of health of these people with them, and also, of course, the assurance that a vehicle will come and they'll be able to go to work. So I think investing in the manpower, in the shuttling of our employees, is really well worth the money that we pay for. As we went along the operations, the biggest problem I think that we met was increasing healthcare worker infection. It was reflective of the community infection. It wasn't reflective of the increasing number of patients in the hospital, COVID patients in the hospital. So why? Because our data shows, and I think Dr. Berba has shown that the occurrences of infection did not really emanate from one point in the hospital, but were a conglomeration of different sites of infections in different units of the hospital, and traced back to their communities or their units only. So I guess this is a reflection again of being probably 1 year into the COVID crisis. People have started letting their guards down, and we were hit by a rash of infection, which is at its worst around 15% of positivity of people tested in a day. So we had between 10 to 20 positive patients a day for around a week and a half. So this is where I always mention that this is a point where we had to protect PGH from the community, and that we employed again the measures of safety officers being more strict, reporting of illnesses online, the allowing more access to the UP Health Service, manned by our family medicine doctors. And eventually, I had to probably set it straight officially by issuing a memo that people found to be in breach of our health protocols will have to put in writing the explanation of how the event happened, not only to remind them that it should not happen, but of course for us to learn why it happened and maybe institute the necessary measures. That step of having them write it down is paying off now. I think people are realizing that maybe it's really sometimes our human frailty that gets the better of us, wanting to share a meal with other co-workers and even probably friends at home. So these are just steps that we did just to remind us that the battle is not over, the enemy is still around us. So having done all of that, I think we were able to more or less contain the ravaging of our healthcare workers, so to speak, early on in the game, and because largely to the systematic methods that our hospital infection control unit has instituted, We also, because of that realization that the work was getting bigger for our small team of infection control personnel, we boosted the number of nurses in the team, hoping for them to be able to do their job better. So I guess it boils down to responding to the surge again in the ways that we have known them and adjusting accordingly to the current abilities and availabilities of resources. We generally, I think even if the current surge seems to be more than what it was in last year's July and August, the lessons that we have learned from being a COVID referral center in the last year has somehow allowed us to manage it more efficiently, with less stress, with less anxiety, but unfortunately, I think we cannot claim that there are less deaths. So because the patients came in really sicker than they were before in the first surge, and unfortunately, the mortality rate has increased significantly also. From, I think we were doing at 12% early on in December and January, when it has risen to around 20% during this surge. So despite all the efforts, I think we just have to identify the areas where we can much improve delivery of care to our patients and hopefully outcome. So a lot of the patients that came in were beyond help already, being out there late in the course of their illness, or maybe unable to find the proper institution to take them in. So this will not be the last surge. I think this current experience that we had made us even more prepared, I think, for a next one, if ever it will come, but hopefully it does not. And the vaccination hopefully also will be able to decrease that. And I'm happy to be here again with you this morning and share the lessons that we will learn in the Philippine General Hospital. Thank you very much, and good morning to everyone.
Okay, thank you very much. That was Dr. Legaspi, PGH Director, again, giving us the whole view and really emphasizing how important it is to take care of our health workers during a surge. And we're going to hear some more. I'd like to introduce our next reactor is the Executive Director of the National Institutes of Health, Eva Cutiongco-De La Paz, who is going to talk about the variants. So we heard from Doc Nina and from Doc Gap about, the risks, transport, behavior, eating together, and so on. But let's look at the virus side. So we've got Dr. Eva De La Paz with us. Eva, welcome to the webinar. Please go ahead with your presentation.
Thank you, Dr. Susie, Dr. Albert. Magandang hapon po sa inyong lahat. Let me just share my screen. There. So we always hear that we are fighting an unseen enemy in this pandemic. I think sequencing somehow allows us to see that enemy through its genome, and it gives us the opportunity to understand COVID-19 better. What I'd like to share is how sequencing the virus helps the response to COVID-19, just like what Dr. Berba has mentioned in her excellent talk, and also from a country perspective. During the initial stages of the pandemic, countries used sequencing to find out how many new cases of disease are imported or come from local transmission. And global databases of virus genomes enabled researchers to compare genomes from country to country. In this slide, you will see the phylogenetic tree of SARS-CoV-2 in the Philippines actually last year. Majority of the Philippine samples collected in March 2020, you can see here, were observed to group into clades linked to the outbreak in the cruise ship MV Diamond Princess in Yokohama, Japan in early February. Later that month, passengers and crew members of this cruise ship representing various nationalities, including Filipinos, were repatriated to their home countries. So our Filipino ship crew members were quarantined for 40 days at the New Clark City. Towards the end of March, we did sequencing of some patients admitted to the PGH who had no travel history outside the country, with some having no known interaction with a confirmed positive case, suggesting the possibility already by then of community transmission. And shortly thereafter, we had the hard lockdown from March to May, and we surmised that the further spread of the virus from the MV Diamond Princess cluster of cases was stopped. This phylogenetic tree also shows us the D614G mutation in the months we struggled with increases of cases last year. And here we see in January, when we started the national genomic surveillance, the arrival of the B.1.7 variant from the UK, from a returning overseas Filipino, and our borders were closed at that time and travel restrictions were imposed. The second is virus genome sequencing also allows estimation of epidemic growth rates, transmissions and infections through mathematical modeling of how viruses evolved during the pandemic. This is useful, especially when cases are underreported, because many people who are infected actually do not have symptoms. This graph from Dr. John Wong of Epimetrics showed the possible impact of then at the time last year, January of this year, the impact of the B.1.7 variant on active cases when the first case was reported in our country by our national surveillance. If the variant becomes the dominant species after a month, you can see in the graph, after a month, cases will increase by 28 times instead of just 3 times. So that was the projection. And from there, planning scenarios could be derived from variant control. And according to Dr. Wong, if there will be a reduction in 80% at the end of the month, after 30 days, the country could have just a little more cases compared to having no variant. And this is having no variant. That's the baseline. This is 80% reduction in the cases. So the call was for efforts should be focused on reducing the baseline cases. Third, widespread sampling and genome sequencing allows the reconstruction of virus spread in different places or groups of people. This provides information about what is driving the spread of the virus, both locally and nationally, especially combined with information about where, how, and when people traveled internationally. We will also be able to know whether these patients present with more severe disease. This is the current, to date, data we have for the variants of concern. So in the Philippines, we have the B.1.7 as well as the B.1351 variants of concern, which comprise 34% of all of the almost 6,000 sequences from RT-PCR positive samples in the country. Of course, you all know that we're not able to sample all. We do purposive sampling of cases from different regions of the country. All the NCR cities now have a variant of concern, and 14% of the cases with the variant were from incoming international travelers. Using this data, we were able to estimate rates between areas with and without the variants of concern. You can see here in a steeper rise in areas with variants of concerns. And you can also see that in areas where there's only one variant of concern, like the B.1.7, or when there's only the B.1351. But together, it will show a steeper rise. And areas contiguous to these places with variants of concern, here, the orange one also shows increases in cases, however slower. Areas without the variant have a plateauing trend. This information was actually used to decide on the lockdown in the NCR bubble, which we experienced about in the early part of April. Fourth, unique genetic changes shared by all these infected in a single virus transmission chain can be identified using sequencing. This can be used to distinguish whether two clusters of cases in the same area have arisen because one started infection in the other, or because there were two distinct and independent chains of transmission with separate earlier origins. Valuable information from genome sequencing can actually enhance contact tracing efforts or track outbreaks in communities, hospitals, and other care settings. And you've seen that in the example that Dr. Berba said in her lecture. And one other good example of this is when genome sequencing shows there are 5 identical SARS-CoV-2 viruses within one workplace on the same day, suggesting COVID-19 transmission going on in that workplace. If there's no knowledge about the sequences, we know there are 5 cases, but we will not know if they were related and whether they constituted an outbreak. It is possible that all 5 cases could be different, meaning they have separate sources and do not represent a cluster. In this diagram, we see that each node here represents cases where transmission could have been prevented had minimum public health standards being correctly practiced, and if they were detected, contact traced, and isolated in a timely manner. When this information came out, there was an all-out effort by our local government units to address these gaps. So we really need the cooperation of everyone. And lastly, we all know by now that sequencing is important in detecting variants. Many genetic changes that occur in the genome of the virus will have no significant effect on the course or infection of disease or the impact of control measures. However, there are variants that concern us. And there are also variants of interest. According to the WHO, there are now 3 variants of interest, and you must all be familiar to those by now. And these are your B.1.7 in the originally identified in the UK, the B.1351 identified in South Africa, and the P.1 identified in Brazil. So 3 variants of concern, but about 7 variants of interest. So I put here another definition of a variant. It's a variant of high consequence. And according to the US CDC, this has clear evidence that prevention measures or medical countermeasures have significantly reduced effectiveness relative to previously circulating variants. So I hope that this will never happen, that we will have a variant of high consequence. So I just want to emphasize there, we don't have a variant of high consequence yet. We do have 3 variants of concern and 7 variants of interest. Just to end this short reaction, this is the P.3, the variant first identified in the Philippines. This shows geographic distribution of the viruses in March when we first reported this from 33 patients when there was a surge in Central Visayas. On the right, one can see that the emergent variant, this one, the red one, forms a monophyletic clade separate from other known lineages globally. So this is for your B.1.28. This is your B.1.7. This is your P.1. And this red one found in Central Visayas is your P.3. So what we can see is that local and global genomic surveillance systems operating in real time are key tools in the armamentarium of public health measures. And our next big challenge is immunosurveillance, which will look into the virus immunological indicators related to infection, disease development, and disease endpoints, including the effects of therapeutics such as drugs and convalescent plasma, as well as the effects of vaccination, and how in general and how vaccine variants will affect vaccine efficacy. And fortunately, the Department of Science and Technology Philippine Council for Health Research and Development is establishing the Genesis program, Genomic and Immunosurveillance System, which is being proposed as an integrated, organized framework of research areas on COVID-19. Yun lang po at maraming salamat po sa lahat. Thank you po.
Okay, thank you very much. That was Eva Cutiongco-De, Executive Director of the National Institutes of Health. And Eva, there are lots of questions in the Q&A box and lots of questions in the chat box. And I'm looking, I can see that we're going to have a lot of questions on the panel. So I'm going to turn over to Albert for our next reactor. So I've been introducing my classmates, so it's your turn. So Nina and Gap, I've been introducing. So it's time to introduce your classmate. Go ahead, Albert.
Sabi nga po ng mga millennials, it's time to confuse them. Who is Albert and who is Raymond? Sabay kami ngayon on the screen. So one is the moderator and one is actually a panelist this afternoon. I'd like to introduce, it is my pleasure and my honor to introduce the next reactor, a familiar face to all of our regular viewers, definitely familiar to me for more than 5 years before we graduated from medical school. And he does not need any formal introduction. Please welcome the director of the UP Manila National Institutes of Health, National Telehealth Center, and the recent TOYM awardee. Magandang hapon, Dr. Raymond Francis Sarmiento. Over to you, Raymond.
Thank you for the kind introduction, Dr. Albert, the classmate and friend. Let me just share my screen and I will just give a brief reaction po, no, to really excellent presentations given by Dr. Nina Berba, Director Gerardo Legaspi, and my boss, NIH Executive Director Eva Cutiongco-De po. I will be talking about one of the tools that we had already, we are still using in UP Manila. It all started po around April, May of last year. And we were trying to figure out how we could contribute in terms of being able to track symptoms through self-reported means and how we could leverage technology as part of it. All of the reports that have been given really emphasize po the importance of data and saan po natin to makukuha. Siyempre, kailangan po maganda ang ating data capture system. So what I will be presenting will be the UP Manila Bayanihan na Employee Symptoms Tracking System. We have already expanded it to include other staff and also the students, and it's something that really very much used in the campus of UP Manila po. The application po runs on a web browser. We use po kasi a progressive web application in order for it to be used in the smartphone, so that when you are visiting the URL, ang URL po, ulitin ko lang po, https://best.upm.edu.ph. Ito po ay mahanap po sa inyong, well, when you open your browser and you go to this link, you'd be able to enter, assuming that you have an account already, and we, because of our security and privacy policies in place, we are making sure that those who are logging in have a up.edu.ph account para po makapag-log in. But for the progressive web application part of it, once you have logged in, assuming you do not clear your cache, you'll be able to use it just like any other application that you have on your smartphone. It will also give you notifications kung meron pong notifications. I'll talk more about the notifications and the alerts later in the next few slides. The application works well in Google Chrome and Mozilla Firefox. It obviously needs internet connection with no personal data being stored in the user's devices po. What we have implemented po is a role-based access with each of the levels and privileges being granted based on whether you're an employee, staff, or student, or you are the head of that unit, or in UP Manila po kasi meron po kami mga focal persons per college or per unit po, and then the head of that college and unit will be on level 3, and then obviously leadership, the chancellor, the vice chancellors will have to have level 4 visibility on everything from registration, symptom encoding, submission of symptoms, and viewing of all of the data that has been presented po. This shows po our employee monitoring form. You will note that you'd be able to add a record there, enter your temperature. Please note, we wanted to make sure na wala pong daya kapag mag-enter po ng temperature po nila. You cannot enter a temperature reading doon po sa ating PM field kung ang time po ninyo ay before 12 p.m. So it really encourages you, it forces you to be able to input data in the morning and in the afternoon. Kung meron po kayong symptoms, you just click on the tick boxes here, and if you have exposures to anyone na may COVID-19 po. What happens after you submit that is that there is an alert that is sent to your supervisor, and then it also tracks whatever action that you did. Meaning, have you reported to the Bayanihan na Operation Center 155200? Have you reported to the UP Manila Health Service, or have you reported po to your local clinic or primary healthcare clinic? Kasi po a lot of us are working po at home, and that's something that we wanted to make sure that there is an intervention. And then kukulitin po kayo ng kukulitin kung hindi po kayo nakapagsasubmit pa ng inyong datos for the day. And then for those who would want a printout, especially for those who would be requiring a barangay certificate, no, kailangan po na meron po, well, kung there would be a need to print it out, there is a functionality in the application that would allow you to print out anything that is recorded in that application. For the reports generation, depending on your level, and in this example, I'm using po the level 4 example para po makita po lahat. Since the very first time na sinimulan po itong application up until whatever time that you want it in terms of the filtering of the dates, you'd be able to do that. There are quick filters, yung pong today, yesterday, last 7 days, and last 30 days po, no? And depending on whether you will just want to see a particular unit or a symptom na kailangan po ma-select po doon. Reports are viewed po as follows, and I will be showing the latest po for UP Manila. So for the last 14 days, hinugot ko lang po ito kaninang umaga, 6 a.m. po ng umaga, no? 14 days po, that, even though it says 15 days, I will venture into saying na it just 14 days po, no? The ones that are the ones being shown here are the number of users with symptoms per date and as assessed by the college or office. So the following UP Manila colleges offices that have submitted the most number of reportable health status within the last 14 days, yun po yung National Institutes of Health. Yan po yung ano ba to, purplish, pink purplish na color po, na parang bell curve, and then the light blue one, College of Medicine, and then we have the College of Allied Medical Professions, and we even are able to track, assuming that you are using the application, those that are in the School of Health Sciences po, no, kasi jurisdictionally it's under UP Manila. Therefore, we are grateful that they are using the application. In terms of system utilization for the last 14 days, on those who have submitted their assessment po, regardless kung may symptom po sila or wala, may exposure po sila o wala, these are the units po that have been submitting consistently to the best: the College of Medicine, National Institutes of Health, the Central Administration, Philippine General Hospital, and School of Health Sciences. The main takeaway message here po kasi is that if you are able to identify based on how many users are really yung masigasig po na nagsasubmit, no, you'll also be as a consequence be granted po a way to be able to understand in terms of the cases in that particular locality. So expanding po beyond the hospital and into the whole of UP Manila, something to think about given the mobility, the level of mobility po ng ating mga individuals and staff and students po, no? In terms of policy, we continually reiterate the use for utilization and compliance po. As mentioned, we started May, June, July, and there have been multiple memos from the Office of the Chancellor to be able to have the individuals, to do their self-reporting through the BEST application po. And then finally, this is a gist of the mobile version of BEST. Right, currently po, we have more than 3,000 registered users in UP Manila community. We want to be able to share this with other, in terms of utilization with other constituent universities po, no? So that this is something that will be helpful, especially with the tracking of the symptoms for their staff. Okay, maraming salamat po, and we're looking forward to the panel po.
Thank you,
very
Dr.
much.
Sarmiento.
Go
The
ahead,
best
go
ka
ahead.
talaga. Best's the best. Sabi nga ni Dr. Anthony Cordero, patented expression yun, the best yung bests. You know? So we can see now how this is a really telemedicine, no? Paano natin nagagamit ang technology to also protect our institutions from a surge rather, no? Yes, Ma'am Susie.
Go ahead. Okay, so we have our last reactor, but not the least. We're very fortunate to have a hospital director of a huge hospital in Metro Manila, the East Avenue Medical Center. Napakalaki po niya, at napakarami tinutulungan. It's my honor to welcome Dr. Alfonso Nuñez III. Cito, welcome to our webinar.
Good afternoon, Dr. Susie and Dr. Berba, Chiong. Thank you for having me here. Dr. De La Paz, thank you for having me here. This is really just a reaction of what we have heard the past few minutes. I have no slides to present, but listening to the lecture or the sharing of Dr. Berba and Dr. Legaspi, parang nakikita ko yung nangyari sa East Avenue. So it's almost the same, including the different controls mentioned by Dr. Berba, the issues about the healthcare workers, and of course the story of Dr. Legaspi. It's like hearing what happened to East Avenue Medical Center last year until now. For Dr. Berba, thank you very much, Doctora, for your very comprehensive and general sharing of what happened to PGH. And indeed, the controls you have mentioned really help your institution, evidently. But there is one control that particularly in East Avenue Medical Center, we had some difficulty, which is the engineering control. East Avenue Medical Center is an old building. We never thought of this pandemic happening to us in this large scale, and because of the old infrastructure, we have several problems modifying our infrastructure. And unlike your hospital, when you started surveillance very early in East Avenue Medical Center, because we do not have the luxury of a molecular laboratory that time last year, this is very hard to do, the disease surveillance of our healthcare workers. But we have learned this lesson last year, and then we have established our own molecular laboratory. And we foresee this molecular laboratory to expand in its scope, not only testing infections, but also we would like to venture into DNA detection and cancer detection as well. I would like to congratulate you, because you are now in the zero surveillance phase, and this is where we want also to be. This is a very good aspect, what you are doing, and very significant also what you have shared in terms of your healthcare workers as to the nature of their infection. And we have also done that in East Avenue Medical Center. We would like to know initially with this second surge if the infection of the healthcare workers was quite unique to us, or are the engineering controls and the protocols, we need certain revisions on them, but we found out that healthcare workers being infected is no different from the general population. And we also have found out that healthcare workers exposed to COVID areas is no different from healthcare workers exposed to non-COVID areas. So really there is some issue in transmission happening outside of the hospital or outside of the workplace. And one aspect that we have identified is transmission during travel and to and from work, because when the restrictions were loosened into GCQ, that was when travel was quite open, and we have some problems in transmission, and we suspect the transmission is happening during travel. And because of that, East Avenue Medical Center invested heavily on accommodation, and we have secured the services of at least 4 hotels. We have also accommodation facilities hosted by our local government unit here in Quezon City. And we found this to be quite effective because the hotels, we can easily control them. We have safety teams posted in these hotels, and on a day-to-day basis, we can monitor the health status of our healthcare workers. And one good practice also that we did in East Avenue Medical Centers is equipping and assigning safety officers in all offices, be it clinical, be it admin, even the motor pool janitorial offices, meron silang naka-assign na safety officers. And we have equipped the safety officers regarding the competencies required to properly monitor healthcare workers or their fellow personnel within their office. One difference between the PGH and East Avenue Medical Center, because PGH has information on the variants, but kami sa East Avenue Medical Center, we do not have the luxury of having these informations. We have actually sent samples to the Philippine Genome Center, and I guess no news is good news. That's what they're telling me, because if the facility does not report on a variant happening in East Avenue Medical Center, then that's good news to us. Well, again, hearing from the sharing of Dr. Legaspi, it's like hearing East Avenue Medical Center's story. And during the initial phase of the pandemic last year, we started with just 5 hospital isolation beds. And we thought that this is okay. And we have our infection control protocols, and we thought that this would serve us to protect us. Based on our experiences with the H1N1 virus, based on our experiences with the Middle East virus, the Hong Kong virus as well, and the Ebola, we thought that this was okay. But slowly, the 5 beds, we had to expand to 50 beds. We had to expand to 120 beds. And at the end of 2020, we were doing somewhere between 180 to 200 beds dedicated for COVID. And we stepped back a bit, and to get a clearer picture of the general situation of East Avenue Medical Center at the time, we noticed that our patients, the main building, we have converted the main building into COVID and non-COVID patients. And this puts a lot of strain on our healthcare workers, knowing that they are going to the same building, working the same area with COVID and non-COVID patients. For example, the 6th floor is dedicated for COVID, and the 5th floor and the 3rd floor is dedicated for non-COVID, and the 3rd floor is dedicated to COVID. So it's a very stressful environment. So what we did in East Avenue Medical Center, we had a newly constructed 5-story building initially intended for wellness, but management decided to convert this 5-story building into a COVID hospital, separate from East Avenue Medical Center main hospital, so that we can safely and dedicatedly contain all COVID activities in that hospital. Now that hospital, we have dedicated 275 beds to respond to COVID patients. And in that building, there is a dedicated emergency room, a dedicated operating room, dedicated delivery room, a dedicated hemodialysis center, and an ICU with a dedicated CT scan, X-ray, and ultrasound. So it is that all activities in that building are COVID activities, and the main hospital of East Avenue Medical Center, we can now slowly go back to non-COVID activities. We have found this to be effective in terms of relieving the anxiety and fear of our healthcare workers, and also some of our patients and other stakeholders interacting with the main hospital. And just like PGH, East Avenue Medical Center recognize the healthcare workers as the most precious resource. These times, this is the most utilized. And in East Avenue Medical Center, this is the most protected and most cared of resource that we have right now. And what we noticed during this new surge, our healthcare workers' anxiety level went down because they can containly schedule their activities in the new building. One aspect with the healthcare workers that we have learned during the last year is that when anxiety goes into fear, fear goes to confusion, and confusion goes to anger, and then everything breaks down. Management is in heated argument often with our healthcare workers. And for this year, we made sure that the anxiety does not transform into fear. And if it goes into fear, there is this active participation or active involvement of management to relieve the fear, control the fear, and to assure our healthcare workers that they are being taken care of. We have still continued the accommodation of our hotels. We have also increased our testing capability of our healthcare workers because we have established our own molecular laboratory. We have been testing our healthcare workers at the rate of around 100 to 150 a day. This is a far cry of what we are doing last year when we are at the mercy of molecular labs outside our institution and with other hospitals as well. Maybe this is the short and long of what we are doing in East Avenue Medical Center. And right now we have dedicated 275 beds to COVID. And 2 months ago, when we were hitting around close to 100%, we are now doing around 61% utilization of our beds. Last month, we were close to 200 healthcare workers that are active cases, but now we are down to around 27 active cases right now. And hopefully for the next few days, these cases will turn out to be recovered again. Again, I would like to thank everybody participating, and thank you for listening to my reaction and sharing of East Avenue Medical Center. Thank you very much.
Okay, thank you very much. That was Dr. Cito Nuñez, the director of East Avenue Medical Center. Again, another very inspiring story of all the hard work that goes into keeping our health workers safe, at the same time responding to a surge. So congratulations, Doc Cito. We were very happy that you made it, and we really look forward to hearing more from you as we progress with the webinar series. So maybe another time we can also invite you to talk about to talk about how your new building is going. I think that's really that is really a very inspiring story and something that we all look forward to hearing from more about. We want to hear more about that. All right, we're going to call in the rest of the panel. So Dean Charlotte Chiong, we're going to have Nina Berba, Eva, Cito, and Raymond. And did I miss anybody? Okay, so we're going to start off. We'll start off with a couple of sort of discussion questions. So Dean Charlotte, are you here? Is Dean Chong here? Okay, all right. So let me start with this question because I want to try to tie together what we learned today. Okay, so we heard about all the kind of infection control measures, but I thought that, and including Raymond's presentation on an app, right, on a digital platform to help monitor health workers. But I wanted to ask, and Cito pointed out to this a little bit, right? Okay, PGH is able to do genome testing, and because of that, we're able to identify and contact trace and be more quote-unquote aggressive in terms of controlling the spread of a variant. In the absence of that, right? Kasi right now, sa UP pa lang nagagawa, sa PGH pa lang nagagawa. Merong, I think some hospitals are being asked to submit, but they don't have the full access. So maybe my question is for Nina. What is the proxy or what can we learn from this that can be applied in other hospitals? Like, is there a certain profile of patients who are infected with the variant na based on symptoms, suspetsya namin variant to, kaya kailangan matindi ang contact tracing, kailangan mas maingat tayo. Meron ba tayong ganun, Nina?
Parang ano ka lang to in my mind, pero more or less also the guidance that the Philippine Genome Center is giving us. So when patients' clinical courses are different, like mas aggressive, particularly younger individuals behaving as if they're more sick than what you expect them to be. Parang tinatag namin sila as possible variants. And we really try to get their nasopharyngeal swab samples, made sure that they're on their way to PGC. When they're overseas workers, when they have linkage to overseas workers, so relatives sila ng somebody who came back to the Philippines from countries that supposedly have these variants. At saka reinfection, when persons come in, they've been documented to have been infected previously and then comes in again with a new infection. And also, I think yung mga magbabakunahan tapos magka-infection despite being quote-unquote fully vaccinated, they'll be included in the list of people who should be parang preferred customers for genome sequencing.
Okay, so short of that, we've mentioned 4 things, no? Symptoms and age, possible exposure to an OFW, ano bang sabi mo pa? Reinfection, no? Parang nagkaroon silang infection tapos nabakunahan pero nag-infect pa rin. Parang dapat medyo alarm na ng konti, and that might be the subject of greater contact tracing because contact tracing has really been a problem in the country. But from the point of view of the hospital, if you have those kinds of patients, that means you put on high alert, you put the community or the LGU on high alert. Na oops, di ba? Papaaral namin ito sa Genome Center kung maaari, pero baka ito ay variant na dapat bantayan natin. Albert, you had a question, and I know this question is in the air. So Albert, go ahead and ask your question about transmission. Go ahead.
Yes, Ma'am Susie. So let's, I will actually invite si Maria Regina Pacifico, ma'am. So you can switch on your video, but I'll just introduce a bit. Pero kayo po yung magkaroon ng question nyo, no? Meron siyang tanong about air conditioning. And to put it into context, there has been a change in advice. So it started with this paper in the Lancet where 10 scientific reasons to consider that the transmission of COVID-19, of the virus of COVID-19 is now airborne. Kasi yung tanong ni Ma'am Regina, Maria Regina Pacifico, sige po ma'am, please join. I understand you're in the panel. Yes po, please go ahead and ask your question.
Good afternoon po sa lahat. Thank you so much for your wonderful webinar, no? Very timely. Ask ko lang po, yung sa workplace po, kung walang bintana na open, air condition siya, paano ho ba, air purifier ho ba ay nakakatulong, no, para sa pag-strengthen ng safety protocol? Thank you po.
Thank you, ma'am.
Who
And
wants to
maybe
answer?
let's,
Yeah.
who would want to answer po? Ma'am Nina? from one Regina to another Regina, Ma'am Nina.
Hi, Ma'am Regina. So, yun. Yung tungkol lang sa airborne, kasi medyo marami rin ako nakitang questions about it. No? So, sa hospitals kasi, parang we know na gano'n naman talaga, droplet, a little bit airborne, na aerosolized, lalo na kung may aerosol generating procedures. Now, in workplaces, we need to just quote-unquote improve ventilation. Parang you put in more fresh air. So, you ask, kung centralize your air conditioning, you ask the engineers in the building to parang, yun nga, increase entry of fresh air into the rooms. Tapos may way of exhausting, parang hinihila mo yung used air within that confined space. Kasi sabi mo walang windows. So, engineers supposedly of buildings, large areas, commercial places know about this. So they can manipulate the controls of your air conditioning system. HEPA filters, good auxiliary equipment. So bibili po kayo nung kung ano yung size ng space na kailangan ma-filter. That's the parang merong mga ganung guide dun sa bibilin nyo according to the specifications of the particular equipment you will buy, according to the size of your room.
Thank you, Nina. Doc Sito wants to say something. Sito, go ahead.
Yes, ma'am. For doon sa question, yun ang naging problema namin sa bagong building, because when we were constructing the new building, ang mindset namin to air-conditioned building, less ang windows, including our operating room. When we were renovating that, yung mga malalaking windows ay niliitan namin. This is the East Avenue Medical Center at Old Hospital, 1969. It was designed by the Americans, and fortunately, yung main building, ang ganda ng ventilation flow, ang airflow, napakaganda. But for the new building, dito kami nagkaroon ng malaking challenge. What we did was, pinutas namin yung ibang mga windows, mga glass windows. We placed their exhaust fans. We invested heavily on portable HEPA filters, medical grade, and also on commercial filters for the offices. Ganun din yung mindset namin noon before the renovation, yung mindset ng mga tao na mas air-conditioned yung office, liitan yung mga windows, etc. etc. But ngayon kasi nag-iiba na naman yung namin, yung strategy and mindset, and we have very much to consider ventilation talaga. And we are now in the process of procuring portable negative pressure devices, yung bang plug and play devices that you can just install externally sa isang area like the operating room, the DR, and the emergency room to create some negative pressure dito. This we have not thought the past several years, and ang investment namin dito really is almost none. But now, nagkakaroon kami ng risk strategizing and rethinking.
Okay, so the environmental measures are really very, very important. Albert, I think we have another live question.
Yes, and actually I was putting in the chat, Doc Susie na Ma'am Susie. This next question naman from Razel Azucena. Sir, bago kayo mag-question, we will give all of our five parang panelists here a chance to give their perspectives, no? And parang when you hear the question kasi, medyo pinisuspense ko yung mga tao. Ano ba yung tanong ni Sir Razel, no? So we would like to hear in this sequence yung mga responses po. First, kay Dr. De La Paz, what is your comment on, sige na, sabihin ko na yung question. Sir, kayo muna yung question bago ko sabihin yung flow. Ano po yung tanong niya, sir?
Patanong mo na.
Okay po, maganda nga po sa inyo lahat. Tanong ko lang po, di ba meron po tayong bagong variant galing India? Gaano po tayo kahanda o are we ready or paano po ba ang gagawin natin?
Thank you, sir. No? So, I'd like to direct first, lahat po tayo dadaanan natin, but first to Dr. Eva Maria Cutiongco-De La Paz.
Thank you,
India
Albert.
variant, or
Thank you.
B1, ano ba yun, ma'am? Yes.
B.1617 variant. Sa ngayon po, ngayong oras pong ito, kasi maya-maya po pag naglabas na kami ng resulta, mag-iba na po sagot ko, no? But sa ngayon po, dun po sa mga 5 samples na 4 na Pilipino at 1 Indian na nagpa-RT-PCR positive, hindi pa po natin nadidetect kung sila ay meron po nitong B.1617, hindi pa po. Subalit sila ay nag-travel from India, tapos dumating po dito sa Pilipinas at sila ay nag-RT-PCR positive. Pina-prioritize po namin sa Philippine Genome Center ang pag-sequence po ng swab sample nitong mga returning overseas Filipinos na ito po, Sir Razel, sa ngayon po. So wala pa po tayong documented case dito sa Pilipinas. Sandali lang po yan. Pag mabilis lang po namin nagawa yung sequencing, nakarating na po yung mga sample sa amin, mabibigay po namin ang kasagutan. Yun lang po. At kung tayo po ay handa, actually po, di ba po nakita nyo na ang variant po naman kasi, yung virus, pareho pa rin po ang kanyang way na pag-transmit, pareho din po yung COVID-19 virus, variant lang nga po siya of the virus. So, yung po mga pinapag-igting nating mga minimum public health standards, yun pa rin po ang mga kailangan gawin. Yung 4 dapat, yung air ventilation, paglalagay ng mask, face shield, right. Physical distancing. Yun lang po. Thank you, Dr. Albert.
Thank you, Dr. Eva. And that's the segue, actually. I'd like to pass over to Dr. Nina Berba. Ma'am, nung kayo ba ay mga nakapick up nung iba-ibang variants sa PGH, nag-iba ba yung practices nyo or the same practices na yung mga minimum public health standards? Pare-pareho lang ho ba yan kahit iba yung variant? Kasi yung tanong ni Sir Razel is, paano na to? Kung sakaling may bagong variant, mag-iiba ho ba ang IPC? Dr. Nina Berba.
The general principles are the same. Siyempre natakot kami. Yun yung meron talagang medyo intense on our side, yung fear. Kasi ang daming sabay-sabay eh. Tapos may fear ka na kakalat sa buong ospital, makikripple yung entire hospital system. Pero in the end, that's why we shifted back to, di ba, may phase kami na parang naging quote-unquote, I said martial law. Kasi we needed to find out for ourselves kung we needed that much of really being very strict with everything. Pero after a while, we noted na walang difference. The same level of infection control policies, whether variant or non-variant, should be the same. So kahit hindi nyo malaman na, kahit wala kayong news from the Genome Center na na variant yung mga na-submit nyo, yung pagka-intense and pagka-strict ng compliance to everything we know should remain.
Yeah, Nina, I was going to ask follow-up question, right? You did decide to do an exit swab on day 15, right? Were you speculating that maybe the infection of the variant lasts longer than the dominant strain?
Yeah, we were speculating that. And kasi yung umpisa, sobrang dami kasi talagang number of healthcare workers. There were days na we had 20 new cases. So you would think na nagkakahawahan talaga sila. So, pero in the end, the same findings that everybody else across the world learned before us, na ganun nga. Let me clarify that kasi baka nakalito ko sa some of you. We don't do that anymore. We went back to the usual policy na hindi na kailangan mag-swab. So as long as ma-finish yung 14 days of isolation for symptomatic individuals, there is no need to swab anymore. We believe people become not infectious anymore, whether it's a variant or a non-variant.
Parang mahirap isipin na si Nina Berbang in charge ng martial law sa PGH, no? Sige. Okay, right. So wait, we'll take a little break on that. And Albert, do we want to go back to our Mentimeter questions and then we'll go into some more questions? Just a few more questions.
Sure.
Yeah.
Yes, ma'am. Sige po. Let's have a look at the Mentimeter. And remember, tinanong po natin kanina, no? This is the first question. When is a symptomatic patient most infectious? A, upon exposure to confirmed COVID-19 case. B, day 1 of the appearance of symptoms. Or C, when you get the results of your COVID test. Dr. Berba, ano po ang answer natin?
So, ang answer yung on the first day of symptoms. Ang totoong answer dyan ay few hours before, yes. Diba? So pag may sinasabi ko pa na, pag may lagnat ka today, siguro kagabi infectious ka na. Pero reality-wise, parang madali lang maalala, on the day you start getting your symptoms, yun ka pinaka-infectious. So isolate ka na kaagad. Even before you know it's really COVID, but you feel you're sick and you were exposed previously to somebody who may have COVID, isolate ka na. Don't wait for the results of the test. Thank you.
All right. And for the second question, let's look at the second question from the Mentimeter. Yan. Ito naman po, why is it important? So alam niyo na kung kanino nanggaling yung questions. No? Why is it important to do genomic surveillance of emerging variants? I'll just read the choices. It will help detect if a variant spreads more quickly in people. It will help determine if a variant evades specific diagnostic tests. It will help detect if a variant causes more severe disease. It will help determine if a variant can evade vaccine-induced immunity, all of the above, or none of the above. Dr. Eva, ano po ang ating answer for this question?
Ang tama pong, the correct answer is all of the above. Very good. So, very good ang audience.
When in doubt, answer all of the above. Joke lang po, pero lahat po kasi ng mga ay correct yung answer. All right. So coming from those two Mentimeter questions, I'd like to pass back. So balik tayo dun sa question ni Sir Razel kanino tungkol dun sa B1617 variant or properly known as first discovered in India, no? So yun pong B1617, ang gusto ko itanong kay Dr. Nuñez. So nakwento ni Dr. Berba na hindi naman talaga nag-iiba yung general principles, pero syempre nakakatakot when it comes to a staff perspective. Sir, from the perspective of East Avenue, nakwento niyo sa lecture, sa reaction niyo kanina, yung biglang dumami yung rooms from just a few to ready na ba ang East Avenue kung sakaling mag-announce mamaya sila Dr. Cutiongco-De na oo nga, B1617 nga. It could happen, but are you ready po sa East Avenue? Yes, Doc.
As far as East Avenue Medical Center is concerned, and maybe sa lahat ng hospitals, ang importante yung treatment management should be very assured sa mga pasyente. And actually, we have done this East Avenue Medical Center. During the low periods started October, November, December, we have prepared the hospital for any eventuality, including the surge. We have invested or increased our mechanical ventilators from 60, we increased it to 80. Before last year, we have no high flow nasal cannulas. And during the last quarter, including January, February, we have invested heavily on high flow machines. We have acquired or procured 45 high flow nasal machines. And this made the difference sa surge ngayon. ito ngayon yung ginagamit ng mga patients, severe and critical, to avoid intubation and mechanical ventilation, which is an aerosolizing procedure and can spread the virus. So sa amin, as far as East Avion is concerned, hindi masyadong malaking factor kung anong variant yan. Ang sa amin, we have to assure the patient that treatment in East Avion Medical Center is at par with the international community, with the World Health Standards, and what the Department of Health is saying in the guidelines. So yun importante. As far as healthcare workers is concerned with the new variants, then we are confident that the protocols for the healthcare workers in terms of isolation, testing, and quarantine are well in place thanks to our reliable infection control committee.
Okay, thank you very much, Sito. I was going to ask Dean Charlotte and maybe even Raymond. No, how are we preparing? So the question was, what if? Okay, so what if we have what did you call it, Eva? A variant of high
consequence.
High consequence. Okay, so
so
first,
naman po sana yan mangyari.
Huwag sanang mangyari, pero you know, it's better to be prepared, isn't it? So I think when I ask Dean Charlotte, I mean, in terms of our medical students, and how are we keeping our young professionals updated? This is changing by the minute, isn't it? It's like every day bago yung nangyayari, no? So how are we doing that? And I was going to ask Raymond also, what can we do to, what should I say? Of course, people can Google things, no? But kailangan meron direction din eh. Kasi otherwise, you know, the internet is a wild, wild west, right? So, Dean Charlotte, because things can evolve and can go south really quickly, how should we be preparing our students for this?
Well, Susie, they are constantly oriented, no, as to what's happening. Almost like we have regular town hall meetings where actually sometimes Dr. Nina Berba is actually asked to present to them, so they know what's happening in the hospital and elsewhere. So I think in terms of our students, they're very keen on getting this information, and they're very good at that. In fact, they're digital natives. But more than that is that the information that they get, they usually verify. So just last night, I got tons of questions regarding vaccination and what about if they already had another brand of vaccine. So they're quite curiosity driven. And I'm happy to say that they're even involved in our researches on COVID. So some new knowledge coming out regarding COVID are actually produced by our own students, our MD PhD students, our regular students, who join research teams, no? And as we speak, I've talked to the coordinator for the MD PhD. I was telling her that maybe for the vaccination and the vaccine resiliency and capacity building of the Philippines, we would like to have our MD PhD students to be part of the different groups that will look into different modalities of how we can really be vaccine resilient.
Nice. Raymond, ikaw naman, merong mga nagtatanong, yan bang app mo pwedeng gamitin sa ibang ospital?
Ayun.
Okay, so so the application po needs to be tweaked so that it will reflect the inherent units po organizationally that is inherent in that particular hospital or the particular unit. Nevertheless, it's something that will be more than happy to work with the other hospitals so that that would be implemented and deployed in their healthcare institutions. As an aside po, there are multiple other supplementary applications. Dr. Susie, the Department of Health has this Kira chatbot If you have any symptoms, you could just essentially talk to a bot, usually an internet bot. So that's it's a machine that based on the algorithm will tell you the likelihood or whatever steps that you will need to take aside from that. So a lot of those things would be in the, well, since they are digital natives nga po, no, they would be in direct messaging platforms like Viber. There are those that have been implemented in Messenger or WhatsApp. A lot of these things have become avenues for information, but in parallel, the WHO has also emphasized po to be able to verify all this information. That's why infodemic management and infodemics have become such a staple word over the last year, because we want to be able to, with the preponderance of all of the information that's out there, we want to be able to share and confirm yung lang pong totoo at tunay na informasyon.
So Raymond, pwede ka ba daw nilang i-text pagka gusto nilang magpatulong?
Sige po, sige po. Opo. Makikita naman po kami next week and every week thereafter.
Okay. So I think we're coming to a close of our program, and we'd like to set up our evaluation question. And while we're doing that, we hope you can all just participate in this little survey we have, just to give us some feedback on how you found the session, the panelists, etc. Okay, so let's go to our closing. We're going to give a few moments for our speakers to just say their parting words. I think we really need to save our systems during a surge. And I guess the question would be, in your parting speech, would be, what else do we need to do? What else? No? So nabanggit na lahat ng mga ginagawa. Pero ano ba yung dapat pa nating gawin para pag nagkaroon ng surge, hindi matatamaan yung mga health workers natin sa hospital? We're gonna start with Doc Cito. Go ahead.
As far as the hospital is concerned, we have to improve our capability and capacity to respond to not only for COVID, but other future emerging and re-emerging infectious diseases. Maybe baka it is incumbent for government to look into quadrant setting of specific healthcare facilities that would cater to such cases in the future. If you notice, there are certain quadrants, like for example, NCR. There are certain quadrants in NCR that needs special attention because there are certain facilities that are not capable of addressing such situations and pandemic. And maybe ito yung kailangan natin pag-ukulan pa. Second, the hospitals should rethink and maybe re-strategize their future projects and activities that would focus to provide certain resiliencies in their agencies to cope with such pandemics. And maybe third, yung healthcare workers, which I think personally, I think this is the most precious commodity right now or resource. Dapat bigyan natin ito ng sapat na attention, sapat na importansya, not only in terms of providing them incentives, but for the overall picture, making the workplace more conducive, making it more incentivize them in terms of legislation, etc. So I guess what I'm saying is we all have to work together, government and non-government agencies, including the private sector, to really put everything together so that if something happens again, then we are much prepared, we are much confident in addressing the situation. Thank you, Ma'am Susie.
Thank you very much. It's Dr. Cito Nuñez, the Medical Chief or Director of East Avenue Medical Center. Raymond, what else do we need to do?
Thank you, Dr. Susie. So the technologies po are, we really are very technologically savvy po in terms of being able to leverage all of these digital platforms. But technology is only as good as the business processes that it follows, all of the algorithms that the healthcare institutions implement. So these applications, these systems, whether they are fancy or very user-friendly or ultra-functional, will not really be that useful if it's not anchored in the business processes or the algorithms of that institution. Very, very important that when you are trying to implement a technology-aided program, it's something that there is buy-in with each of the different stakeholder groups in that healthcare institution, so that very, very important po kasi lalo na sa pandemic na ito, yung pong compliance. Kayo ba ay willing na magbigay ng datos? Kayo ba ay timely pag nagbibigay ng datos? How accurate it is? Baka nilagay mo lang dyan sa pangalan mo ay Super Mario Brothers. Something na ganun po. It's all of the little steps accumulate if you do it correctly po. And that's something that I think the whole panel shares naman po.
Thank you very much, Raymond. Eva?
I think the message from the genomic surveillance side is the more the virus circulates, the more opportunity it has to change and acquire new mutations. And so the important message is we need to keep the number of cases down by being responsible and doing our part in practicing the minimum public health standards so as not to give the virus the opportunity to become better at being a virus. Yun lang po. Thank you.
Thank you very much. Nina?
I have 3 points. So yung number 1, bakuna. Parang 3 points na yan. I think that's really the way to go for all of us to be better protected against the virus. Number 2, stay vigilant with complying to infection control. Minsan inisip natin, ano lang siya matter of fact, pero we really need to stay vigilant with everything that we know so far. And number 3, pagka na-combine natin yung being vigilant and being bakunado, the next step is to really choose safe options. So safer options for all of us in the future. Thank you. That's it.
Thank you very much, Nina. And Dean, Charlotte, please.
Well, the SOS, I think, is really just solidarity of everyone and oneness in unity. So everybody is in this boat together. So vaccination, safety protocols, we all have to follow that. And of course, yung science. We really see that science is very important in our fight against this pandemic. And we're very happy that we have the expertise here and we have that spirit of collaboration and bayanihan to get us through this pandemic.
Thank you very much. Okay, that was Dean Charlotte Chiong of the UP College of Medicine. All right, so we're going to our closing remarks. And of course, we've got Chancellor Menchit Padilla to round this up for us. Menchit, welcome to the webinar, and we're looking forward to your closing remarks.
Okay, so thank you. So the webinar was opened by the Dean of the College of Medicine, UP College of Medicine, Charlotte Chiong. And Dean Chiong actually gave us a review of the past year of PGH. PGH had to implement new engineering controls in a century-old hospital. The OPD that was servicing 600,000 patients had to close down. And despite all of this, PGH had to remain open. The faculty had to continue teaching because in the midst of the pandemic, we have to graduate doctors, nurses, pharmacists, and other health workers. So the commitment of administration is to maintain safety protocols as we go back to school. Our main presenter was Dr. Nina Berba. And allow me just to highlight a few points. Now, she gave the top 3 best practices of PGH. Number 1, the use of science for better engineering and administrative controls. And by engineering, she meant controlled ventilation to ensure 12 air exchanges. We could not afford to do the negative pressure for all of the wards. The second was administrative controls. They had a complex testing system to keep the wards safe. And she actually reiterated the part that instead of regular testing, which was not economically efficient in a hospital with 4,000 employees, they moved towards targeted testing and on demand when the healthcare worker felt they needed it. And the third best practice was the risk-based HICU levels of PPE. Now, there were two main reasons behind the surge. One was the healthcare worker reporting back to work despite the symptoms. And the second one was eating together. And this was as a result of their evaluation of the problem. And as she said, martial law was declared, but luckily it was short-lived. Masunurin ang community. Sumunod sila lahat kay Dr. Berba or else ma-extend ang martial law. So the lessons learned are actually captured from the various scenarios. One is a healthcare worker who has initial symptoms and continues to report to work. Second is a healthcare working joining a carpool. Number 3 is a healthcare working eating with other healthcare workers during lunch. But she had the same message for all. The advice of Dr. Nina is to comply with all, in capital letters, all pandemic precautions all the time. And she said, avoid breaches in the PPE use. And as she said, they had to identify stricter safety officers to make sure that we never, keep our guards down. Now, she ended by saying that, whatever works in PGH should work for all. So she actually gave 4 recommendations for letter S. 1 is science, use science for infection control. 2, solution, use innovative solutions. Systems approach. 3 is solidarity. We have to work together. And 4th, which I think is very important for PGH, is the strategic risk communication. We actually had 4 reactors. So allow me to start with the 2 heads of a hospital. So Dr. Legaspi started by saying that it is good science that helped PGH manage the surge. She actually shared urgent measures that had to be implemented as a result of the surge. Number 1 was the personal reductions scheme. They sent home all the interns. Number 2, they had to increase the number of COVID wards, meaning closing down more regular wards to give way to COVID patients, and then increasing the personnel in the COVID wards so that they have scheduled rest in between their duties. Number 3 was the use of additional classrooms in UP Manila for housing an additional 100 within the campus. I think right now we're housing about 400 in the different colleges of UP Manila. Number 4, the transportation was managed. I think, the health workers appreciated the shuttle services because it meant avoiding exposure in public transportation. And I think, the last one that he shared was that, and this worked, if there was a surge in a department, the department chair to explain why there was a surge. So Director GAP gives credit to systematic methods instituted by HICU, the Hospital Infection Control Unit of PGH, led by Dr. Berba. Dr. GAP said this will not be the last surge. So the only thing we know now is that we know better. Our second reactor was Dr. Nuñez. And he shared his experiences at the East Avenue Medical Center. And he said the challenges are similar. They had difficulty with the engineering control. They also had an old hospital. They also experienced the surge. And like PGH, they had to increase the number of beds for COVID. But luckily, they had a new building. And this new building, instead of being a wellness center, they have converted to a COVID hospital, which now has 275 beds. So he said that separating the patients, the hospital for the COVID patients and the hospital for the regular patients, eased the anxiety among the healthcare workers. But one thing they realized is that the healthcare workers were exposed to, had the same level of exposure to COVID areas and also from outside the hospital. And of course, they give credit to the hotels who continue to support them. And I'm really happy that they've set up a molecular lab because I really believe that, being as a geneticist, that all hospitals should really have a molecular lab in the midst of their diagnostic test. He said something that's worth sharing. He said, it is the active and conscious management of anxiety of the healthcare workers that they gave priority. Because anxiety leads to fear, fear leads to frustration, and frustration leads to anger. And he said, so long as you keep your health workers free from anxiety, then everybody will be happy in the hospital. Our next reactor is Dr. Eva. and where she explained the value of the genomic surveillance. And so just as a summary, number one, it gave us a history where it all started. We know that it came from MV Diamond Princess. Number two, it estimates epidemic growth. We think modeling is not important. It is important for government because that is the plan for the next step. The third is they are able to verify where the virus is spreading. So where are the variants traveling? And as a matter of fact, this information was used in the very recent lockdown that we had here in NCR Plus. The fourth is it identifies the transmission chain. So, it tracks the outbreaks, it supports a contact tracing. They're able to identify whether there is a cluster. And of course, the last is they're able to identify new variants. So every time we have a new variant that's announced in the world, we know that we have the facility to be able to do that. Our last reactor was Dr. Raymond, and I'm really happy that he actually did this for UP Manila. It's a UP Manila BEST. It's an employee assistance tracking system, which actually an employee is actually expected to log in to this system before they go to work. And there's a level of reporting. And I can tell you that when a dean is sick, and if the dean is reporting, I know when she has fever because that ends up with me. The just a few words from our group. From Dr. Cito, what I gathered from him is that he said, address resilient strategies to prepare for future pandemics. From Dr. Raymond, technology has to be anchored in the business processes. Dr. Eva said, do not give the virus a chance to move around and get better. From Dr. Nina, be vaccinated, be vigilant, choose safe options. Let me end with what Dean Charlotte said. Also in the opening, Dean Charlotte said, to survive COVID-19, we need solidarity. We have to work together, not only within the health system, but also with the local leaders and NGOs using science-based solutions with the cultural backdrop of the Philippines. Thank you, and back to you, Susie.
Thank you very much. That's Manchit Padilla, the Chancellor of UP Manila. And I have my own quote from Yoda, and Albert, unahon kita dito, di ba? Sabi ni Yoda, Star Wars, fear leads to anger, anger leads to hate, and hate leads to suffering. And most of the time, the cause of our fear is the lack of information. So next week, we have some of your favorites. Our topic is going to be, nalilito pa rin ako, frequently asked questions on COVID-19 vaccination. And we're going to have Eric Tayag. So this team that you wanted to have before, dapat part 2, no? So Eric Tayag, we have Dr. Ana Ong Lim, and Ted Herbosa. So vaccination, I think you still have questions from the chat box, from the Q&A. I can see you're asking. You got one shot of Astra. What are you going to do next? Are you going to take the Sputnik vaccine? Ang dami yung mga tanong eh. Paano kung nagka-infection ka? How long until you can get the vaccine? So we will refocus on vaccination next week. So don't forget to join us. Over to you, Albert.
Thank you, Doc Susie. No, may isa pang Yoda quote eh. Sabi nga ni Master Yoda, do or do not. There is no try. Yeah. So we just really need to do as we did with this webinar. And thank you so much to all of our panelists. I'll just quickly read the results of the poll. No, all of our, I would say all, kasi 93% strongly agree and 7% agree. Almost consistently ganun sa lahat ng questions. Everyone agrees, 1,000 respondents, that the panelists demonstrated thorough knowledge of the topic. The panelists were well prepared and organized. The panelists spoke clearly and audibly. The panelists used appropriate language with technical medical jargons adequately explained. And the panelists contributed to new perspectives and knowledge on managing various key COVID-19 issues. As always, it's been a pleasure to fill in for Dr. Raymond Sarmiento, as he was one of the reactors this afternoon. And with that being said, I'd like to thank everyone. This formally closes our webinar for this week. Dr. Raymond Sarmiento will be back with you next week. It's a date.
Together, we can stop COVID deaths.
Stay safe, stay healthy, and stay connected.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others love before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? Oh God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others vows before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others pain before my fears, the others loves before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others pain before my fears, pushing on despite the tears. Please take us through another day. Just hold my hand, and I will hold the line. I will